Okay. And three, two, one, go.
All right, welcome to our session, Bugs and Drugs. I'm Erica Stoes. I'm an infectious disease physician and part of your Department of Health antimicrobial stewardship team. Today, we're going to be talking about spectrum of antibiotics. Our objectives today, we're going to review the microbiology of common infectious syndromes and review the pharmacokinetic spectrum of activities and side effect profiles for common antibiotics. So how to think about antibiotic spectrum of activity. So in other words, what drugs cover which bugs? To do this, we're going to simplify things a lot. And we want to divide bacteria into 4 categories. And these are going to be gram-positive and gram-negative. And when we say that, we're really referring to aerobes. And those are bacteria that require oxygen. And these are ones you have heard of commonly. And examples too below, these are, when we say gram, this is referring to gram staining. So gram-positive stains purple, like the picture on the left, a common bacteria, Staph aureus. And then on the right, gram-negative, using the stain, these bacteria look red under the microscope. And you've heard a lot of these bacteria. We'll go into those a little bit more in the next few slides. And for anaerobes, these are bacteria that do not require oxygen to grow. These are a little bit more difficult, and these are going to be names of bacteria that you are probably going to be less familiar with. For the purposes of this discussion, we're just going to be referring to them in one big bucket called anaerobes and not really get more specific than that. And finally, the 4th category is atypicals. These are bacteria actually that are very difficult to grow in the lab, and they're often diagnosed using a different kind of test, often a molecular test. And these are some examples are bacteria that cause pneumonia like Legionella, Mycoplasma, and Chlamydia. So let's start with gram-positive aerobes, this first category of bacteria. So when we refer to them, these are the bacteria we're talking about. So a lot of people have heard of streps. So streptococci are a very common and important one we're going to think about. Another one is Staph aureus. And as many of you may know, it can be subcategorized as methicillin susceptible or resistant. And that's where the MSSA and MRSA abbreviations come from. There are other gram-positive aerobes that are important, like Enterococcus, especially if you've heard of VRE, vancomycin-resistant Enterococci, and coagulase-negative staph. So those are staphylococci, not Staph aureus, that are important causes of, for example, central line infections. When we talk about gram-negative aerobes, we can really divide these probably into 2 categories. One is Enterobacteriaceae, and that is referring to bacteria that commonly live in the gut or in the intestines. Some examples are E. coli, Klebsiella, and these can be further categorized based on some resistance mechanisms they may carry. And if you're an infection preventionist, these are going to be important ones that you've heard about. So, for example, extended spectrum beta-lactamase or ESBL producers. Some may be carbapenem resistant, and that is referred to as CRE. And then some of bacteria can have a encoded gene called AMP-C, which produces a beta-lactamase and makes them resistant to 3rd-generation cephalosporins. The other important gram-negative aerobe we're going to mention is Pseudomonas. Pseudomonas aeruginosa is an important important bacterial cause of very serious gram-negative infections. And so we'll discuss which drugs cover that organism in particular. And then you have probably, if you had any kind of outbreak or heard about outbreaks with a highly resistant gram-negative called Acinetobacter, that is called crab, that is also a gram-negative aerobe. We will not get into that one so much today. So when we talk about antibiotic spectra, we have now divided these into some subcategories. We're going to go through each of these in depth today. And this is the drug, this is an example, ciprofloxacin. When you see this figure, this is going to be showing that ciprofloxacin here in blue covers many of our Enterobacteriaceae and Pseudomonas. It also covers atypical organisms. But where you see a gap, there's no, this is not colored in for anaerobes, for example. This is referring that ciprofloxacin does not cover anaerobes. As you can see on the left, it also does not have good gram-positive activity. So when you're seeing this figure, I just wanted to orient you to what this is illustrating. So when we think about some common empiric combinations, in particular for sepsis, these are some examples you may see. So these on the left, vancomycin and daptomycin, for example, have very broad gram-positive coverage, whereas they do not have gram-negative coverage. So we would be pairing these drugs with another that has gram-negative coverage, for example, for sepsis. In this example, vancomycin and plus cefepime, there is a little bit overlapping coverage with some gram-positives, but importantly, cefepime covers the important gram-negative organisms. It does not cover anaerobes. So if someone's worried about a gut infection, diverticulitis, for example, then they may add some anaerobic coverage. So anyway, just further examples of how you may see different antibiotics mixed and matched to cover bacteria accordingly. So let's dive into our first major class of antibiotics, and these are the beta-lactams. These are probably the antibiotics you're most familiar with. We can further subdivide these into 3 subclasses called penicillins, cephalosporins, and carbapenems. There are certain general class characteristics. This is not a whole truth for all of them, but just general, is that certain oral beta-lactams do have poor bioavailability. And when I say bioavailability, what am I referring to? This is how much of the drug is absorbed into systemic circulation to have activity against whatever you're treating. So, for example, some oral cephalosporins, let's say cephalexin or amoxicillin, are absorbed systemically, but then they exit and go to the tissue of choice. But if you're having, say, a bacteremia, you're worried about sepsis, you want sustained drug in the blood, then you want to make sure you have one with really good bioavailability. This is why we use IV antibiotics if you're having a very serious infection. But there are certain caveats. So when we step down from an IV antibiotic over to an oral agent, it is common that we'll want to choose an oral agent that has better bioavailability than some others. So an example is amoxicillin clavulanate. If I know that my patient's UTI, for example, is susceptible, then I may transition them to that and choose that one over amoxicillin, which may need to be dosed more frequently in order to get the same activity. So this is just a general characteristic. I wanted to make that point. Other things to think about is that certain beta-lactams can have certain side effects like kidney injury, drug rash, and drug fever. So those are all things we think about. Also, some neurotoxicity is associated with certain beta-lactams with long-term use. And importantly, allergies among these beta-lactams, there's rare cross-reactivity. So while someone may say they're allergic to first-generation penicillins, or excuse me, they may be allergic to penicillins, that does not mean they are allergic to cephalosporins. So you may be able to use a first-generation cephalosporin to treat them if you're treating, for example, a strep. And then importantly, MRSA is resistant to all beta-lactams, so you're not going to be using them for MRSA. Most of these antibiotics for MRSA, the exception is a special drug that is reserved generally for infectious disease use called ceftaroline. We're not going to get into that nuance today. Just a figure to illustrate this spectrum of coverage for penicillins in particular. Here you can see that, let's say amoxicillin and ampicillin, kind of the oral and the IV forms here, do have Enterobacteriaceae coverage, not complete coverage, however, because there is resistance. So we may not want to choose this for empiric coverage, but if we know we're treating a strep, these are great choices. Similarly, here you can see amoxicillin clavulanate and ampicillin sulbactam. When you have this beta-lactamase inhibitor combination, you gain more coverage, including more Enterobacteriaceae coverage and some anaerobic activity. And then piperacillin tazobactam is our broadest penicillin that is used. Again, you can see the spectrum activity here is very wide. So let's move on to cephalosporins. There are many, many cephalosporins if you look these up. These are just a few examples of the most common, and these are also in order of generation of cephalosporin in general, with one exception. But in the top here, these are first generation cephalosporins, cephalexin and cefazolin. The second generation, cefoxitin and cefotetan, have similar coverage. You're going to see as we go through generations, we pick up more gram-negative coverage. The special one about second generation cephalosporins is they have some anaerobic activity. Third generation cephalosporins, these are really go-to antibiotics for many conditions. You can see mainly that's because they cover good coverage for Enterobacteriaceae, but they do not cover Pseudomonas. So ceftazidime is actually a third generation cephalosporin, but does have Pseudomonal coverage. And cefepime is our fourth generation cephalosporin, again with very broad coverage. So just kind of an illustration to show the different combinations and generations of cephalosporins here. Finally, our carbapenems. These are our workhorse drugs for resistant organisms. You can see here that ertapenem, the difference between ertapenem from the other carbapenems is that ertapenem does not have Pseudomonal coverage. But again, very broad coverage here, covering streps, Enterobacteriaceae, Pseudomonas for meropenem and imipenem, and anaerobic activity. All right, so if we move on to our anti-MRSA drugs, so glycopeptides and oxylinodonones, it's a mouthful. We're going to really subdivide these into these three workhorse drugs. So vancomycin, daptomycin, and linezolid. So vancomycin, just a few caveats, many are familiar with this as our IV antibiotic for MRSA. Realize that there is something called oral vancomycin, but it has zero bioavailability, meaning it does not absorb into the bloodstream at all. We do not use it for MRSA. Oral vancomycin is only used for C. difficile infections. When we're using it for MRSA, it has to be IV. This is weight-based dosing, and it's important to consider kidney function as well. And you're going to be monitoring levels and adjusting based on those troughs that are monitored. And then the big toxicity, like I mentioned, is kidney injury. There is a syndrome called vancomycin infusion syndrome. It was formerly known as red man syndrome or red person syndrome. This is actually not an allergic reaction, but a histamine release that can be avoided by just slowing down the infusion. So these are important caveats to know about vancomycin. Daptomycin is another great anti-MRSA drug. The main caveat to know about this one is that it is not your go-to if you're worried about MRSA pneumonia, because it can be inactivated by surfactant, which is a substance that is produced by the tiniest lung cells that would inactivate it. So that's why we don't use that for pneumonia. The major toxicity and something we monitor for is rhabdomyolysis, and that's by checking the CK while patients on this. And finally, linezolid is our other MRSA drug, great bioavailability. So we use it orally when we can because it gets into the blood well and efficiently. Important to know is long-term, it can cause peripheral neuropathy and bone marrow suppression. So not a great drug to use for an extended period. Just an illustration for the coverage of our glycopeptides and linezolid is here. Okay, we're going to move on to a whole different class, and that's the fluoroquinolones. And this is a big target for our stewards. So you're going to hear us talk about this in the future. But fluoroquinolones, why has it's been a great drug of choice for years because it has such great bioavailability and can be used to treat so many conditions. So meaning, again, you take it, it gets into the bloodstream well. Only caveat is you do have to make sure that you avoid taking it with milk or calcium products because that does inhibit the uptake of the drug. But the big downside about fluoroquinolones is all the toxicities that can be associated. Anywhere from GI upset to prolonged QT, which is a certain interval on an EKG. So people who are on a lot of heart medications are people you need to worry about and think about checking the EKG. There's a lot of neurologic side effects that need to be considered, listed here. Also, there's collagen vascular disruption that has been associated. So we have to warn people about tendinitis, retinal detachment, and now there's an association with aortic aneurysm. So we try to avoid these when we can. They're also associated with developing multi-drug resistant bacterial colonization and C. diff infection itself. And just as a reminder, this is not a good drug for Staph aureus, especially monotherapy. So mild infections, again, for why we antimicrobial stewards are trying to steer away from fluoroquinolones is that while they are great for treating UTI and acute respiratory infections, there are usually better and less toxic antibiotics to choose from. So we'll get into that in our practical activity. This is an illustration of fluoroquinolone's spectra of activity against the different bacteria we've talked about. Again, you can see there is a little bit of variation here between moxifloxacin and the other workhorses, Cipro and levofloxacin. All right, we move on to a couple other different antibiotic classes. The tetracyclines, this is the main antibiotic to think about with this one is doxycycline. Doxycycline does have good bioavailability. It gets to tissues quickly, but actually it stays in the blood very little. It goes quick. So we would not want to use doxycycline for infections like pyelonephritis or sepsis. There's definitely better drugs for those, and we're going to use doxycycline or tetracyclines for other reasons. The toxicities associated with this one that are important to recognize are phototoxicity, and that means when somebody goes out into bright light or the sun, it can cause some disruption. Like the sun might seem brighter, you might be needing to close your eyes more, might want to wear sunglasses while you're taking this, and sunscreen. The other really important one to realize is esophagitis. So when there's a patient swallowing this one, you want to make sure they drink plenty of water because if it does stay in the esophagus, it can cause really bad inflammation. There's also some association with drug-induced lupus, which is extremely rare, but also known with this drug. And again, it's not reliable as empiric therapy for gram-negatives. So we're going to use it for only certain conditions. And then macrolides, completely different class of antibiotic. These are things like azithromycin. Great bioavailability. It concentrates in the lungs, so that's why it's kind of the good go-to for respiratory infections, especially our atypicals. The toxicities associated with it are some GI upset, and it is known to prolong the QT. So again, one of those EKG intervals that if someone's on a lot of cardiac medications, they may be, this is one you have to look out for. So just an example here of what the spectra of coverage looks like. These are very different classes of antibiotics. So you can see azithromycin here is really kind of aimed at our atypicals, does have some strep coverage, whereas doxycycline really may be used for skin and soft tissue infections when you're concerned about MSSA or MRSA, has a little bit of, and has some good atypical activity again against those atypical pneumonias. Clindamycin is another antibiotic that's been commonly used for staphs and streps for a long time, but it is we're losing it as a reliable agent because of resistance developing against MRSA. It does have great bioavailability, so you can take it using oral tablets just as well as you if you were to give it IV. But the other big thing about toxicity associated with clindamycin is diarrhea and C. diff infection in particular. Again, this drug is really going out of favor for these reasons. Metronidazole, this is an anti-anaerobic antibiotic. So another one with good bioavailability, meaning if you take it orally, great absorption. It's got toxicities in that it can cause altered taste and nausea. And with prolonged exposure, we're talking weeks, you can develop some neuropathy or encephalopathy. And just a quick look at what these spectra of coverage are. These are really our anti-anaerobic bacteria or antibiotics. And you can see clindamycin had been used as a good go-to for streps and staphs for a long time until we were losing losing it to resistance. Just to kind of get closer to our last few classes here. So nitrofurantoin and fosfomycin, I just put these together when the same, not in the same class, but the same area, because these are our anti-UTI antibiotics. They concentrate in the urine, but they are not systemically absorbed well, meaning they won't have good coverage if you're worried somebody has sepsis or let's say even pyelonephritis or kidney infection. It's going to not penetrate the kidney as well. So we use this for UTI. E. coli in particular is our main one that we're using that for. And the important thing to think about with prolonged nitrofurantoin is that it long-term you could cause pulmonary fibrosis, meaning if we would not want to go to this drug as a long-term suppression for UTI for that reason. And then finally, trimethoprim sulfamethoxazole. This is a antibiotic in and of itself with unique coverage. So again, this one is also good bioavailability. It does have good gram-negative coverage. So in particular, our E. coli, Klebsiella, and Proteus. It also has activity against some strep, though we rarely get sensitivities for it. It is also our drug of choice for pneumocystis pneumonia. If you've heard of that particular bacteria, this is, infection. This is in immunocompromised patients in particular. And then the toxicities associated with trimethoprim sulfamethoxazole include acute kidney injury, hyperkalemia or high potassium, and Stevens-Johnson syndrome. It's incredibly rare, but it's a very serious inflammation of the skin where the skin will peel off. And so it's just important to check for history of that before we prescribe these. Mostly it's about monitoring their kidney function and potassium though. And just our spectra of coverage here, you can see that nitrofurantoin and fosfomycin have really great Enterobacteriaceae coverage, in particular, like we said, E. coli, but really shouldn't be used for anything else. And then trimethoprim sulfamethoxazole has good coverage with some gram-positive and gram-negative coverage. Just to finish out here, I just have some reference slides. We're not going to go through these in depth, but they're just to clarify, these different multi-drug resistant organisms. What are they resistant to and what should you use instead? And some resources when we mention all these different classes, what antibiotics are included within that class. And finally, if we wanted to put it all together, we found this slide. This is courtesy of a pharmacy professor at Drake University, who kind of put all of what I showed you into one big slide. So just an example here, if you wanted to reference all of what we just described in one slide, here would be one example. And just a reminder, if you are watching on YouTube, please use this QR code to verify your attendance so we can get you tracked and on your way to a certificate.